Hello, my name's Ken Milne. The title of this talk is TXA, the duct tape of emergency medicine. Now, TXA has been tried in a variety of conditions over the years, including menorrhagia, perioperative bleeding, and reversing thrombolytic therapy, etc. In recent years, TXA has been thought of as the duct tape treatment for any bleeding in the emergency department, and has been used for many different acute bleeding situations. This lecture is going to go through the evidence for the use of TXA in the emergency department for 7 different indications. Let's get started with trauma. So TXA for trauma. It was the CRASH 2 trial published in The Lancet 2010 that really got everyone's attention. This was a multi-center randomized placebo-controlled blinded trial. Big trial, over 20,000 adult trauma patients treated within 8 hours of injury. They received 1 gram of TXA up front over 10 minutes and then 1 gram over 8 hours. The key result was a 1.5% absolute decrease in death within 4 weeks of injury. So this gives you a number needed to treat to prevent 1 death of 68. Now, sooner treatment seemed better, but this was an association only. Patients were not randomized into early versus late treatment. There was no statistical difference in thrombotic events. They were around 2%, and no increase in adverse events. But we know that adverse events are systematically underreported in clinical trials. So how about TXA for isolated head trauma? Well, this is CRASH 3, also published in The Lancet, but this was 2019. Again, a very well done study, multi-center, randomized, placebo-controlled, blinded trial. They had close to 13,000 adult trauma patients with isolated traumatic head injuries. They got the 1 gram of TXA over 10 minutes and then a 1 gram infusion over 8 hours. The key result for this trial was different, though. They found no statistical difference due to head injury or all-cause mortality. They also didn't observe an increase in vascular events or adverse events. Now, there was a secondary subgroup analysis of less head injury deaths in patients with milder injuries, but this should be considered hypothesis generating, a subgroup of head injury death as opposed to the primary outcome and looking at all-cause mortality. How about TXA in the pre-hospital setting for people with traumatic brain injury? Because it was thought sooner was better. Well, this was in The Lancet 2019, multi-center, randomized, placebo-controlled, blinded trial. The N was 1,000 patients with an isolated traumatic brain injury with a GCS of 3 to 12. They got the same regimen of 1 gram over 10 minutes and then 1 gram over 8 hours, but there was also a second intervention arm that got just a 2 gram bolus. And this was placebo-controlled, so they got it compared to a saline infusion. Their key result was no statistical difference in favorable neurologic function at 6 months. There was also no statistical difference in thrombotic events. All right, how about TXA for postpartum hemorrhage? This is the woman's trial published in The Lancet 2017, multi-center, randomized, placebo-controlled, blinded trial. Over 20,000 women with postpartum hemorrhage. They got 1 gram as a slow infusion of TXA with the option to repeat it in 30 minutes, and it was compared to placebo. The key result, no statistical difference in all-cause mortality or hysterectomy within 42 days. There was a subgroup that showed less mortality due to bleeding if treated in under 3 hours, but again, this would be considered hypothesis generating. There was no statistical difference in thrombotic events, hysterectomy rates, or adverse events. How about TXA for GI bleeds? Well, this was the HALT-IT trial published in The Lancet last year. Again, a multi-center, randomized, placebo-controlled, blinded trial. They had just over 12,000 adult patients with significant upper or lower GI bleeds. They got 1 gram of TXA IV over 10 minutes, followed by 3 grams of TXA as a maintenance infusion over 8 hours. It was placebo saline controlled. There was no statistical difference in death due to GI bleeding within 5 days. It was around 4% in both groups. There was no statistical difference in all-cause mortality. There was, however, a concerning statistically significant increase in venous thromboembolism, 0.8% in the TXA group versus 0.4% in the placebo group. This is an absolute difference of 0.4% and gives you a number needed to harm to get a VTE of 250. But if you wanted to spin that, you could say it was a 200% relative increase in VTE with TXA. How about TXA for intracranial hemorrhage? Well, there's two trials, both published in the Lancet. The TITCH2 trial, multicenter, randomized, placebo-controlled, blinded trial with 2,300 adult patients, 1 gram of TXA over 10 minutes, followed by that 1 gram over 8 hours. No statistical difference in their modified Rankin scale score at 90 days. They did show a decrease in serious adverse events with TXA, but no statistical difference in VTE. It was around 3% in both groups. Now, the ULTRA trial, which came out this year, was very similar, multi-center randomized, but it was unblinded. And the key here was they wanted to treat people as soon as possible because they thought earlier with TXA would result in it showing superiority. They recruited almost 1,000 patients and compared it to usual care, but they did show no statistical difference in good neurologic function at 6 months and no statistical difference in all-cause mortality or adverse events. How about TXA for epistaxis? Well, there are two trials published by the same group in the same journal, one in 2013 and one in 2018. They were the same methodology. It was a single-center, randomized control trial, but it was an active control, not a placebo control, and it was unblinded. The first study just had over 200 patients with epistaxis. They would take a 15-centimeter cotton packing soaked in 500 milligrams of TXA and put it up the nose and then pull it out when the bleeding stopped. And they compared it to cotton packing, so this is the active control, of epinephrine plus lidocaine and then repacked with cotton covered in tetracycline. They found that the result was a number needed to treat of 2, and like, whoa, too good to be true? It might be. Their primary outcome was bleeding stopped within 10 minutes. It was 71% versus 31%, so that is a big delta and gives you a number needed to treat of 2. Discharged home within 2 hours, 95% in the treatment group versus 6%. And patient satisfaction was double and very high, 85% versus 45%. Now the second trial, same setup, except it was just over 100 patients, but the difference was these were patients taking antiplatelet medicine. Same thing though, stopped within 10 minutes, again, number needed to treat of 2. Discharged within 2 hours, 97% versus 13%. Patient satisfaction, 9 out of 10 versus 4 out of 10. So a lot of people adopted this into their care. However, then Rubin et al. Came out this year with a randomized placebo-controlled blinded trial. So that's different, blinded trial and placebo-controlled. They took about 500 adult patients with epistaxis, but these were select patients. They had to have not responded to 10 minutes of direct pressure and 10 minutes of packing with a vasoconstrictor. So you've already narrowed out into selection bias there. Another difference is they treated with 200 milligrams of TXA that could be repeated times 1. So it was a lower dose. And they compared that to a cotton wool dental roll soaked in saline. There was no statistical difference in their outcome, and their outcome was anterior packing. It was in the low 40s for both groups. Now, the difference between the first two trials and this no-pack trial was different patients, right? These were the ones that didn't respond to standard care. In this trial of 500 patients, 65% were taking anticoagulants. They were using a lower dose, and they had a different primary outcome. And the last one I wanted to go through was TXA for hemostasis. This is why Wand et al. In CHEST 2018, a multi-center randomized placebo-controlled blinded trial, but it was small. And what I mean by small was 47 patients. That means half of them got treatment and half of them were in the control group. So a small study, 500 milligrams of nebulized TXA 3 times a day compared to a saline control. Complete resolution at 5 days, 96 versus 50%. So that gives you a number needed to treat of 2. And if you've seen NNTs like this, think that it's probably too good to be true. And certainly with an N of only 47, I mean orders of magnitude smaller than the CRASH 2, CRASH 3, and the woman's trial, really can't comment on harm. So to summarize, TXA for bleeding in the ED. Trauma, I've got a check mark yes. Crash 2 had better mortality and absolute risk reduction of 1.5%. But I have to tell you, my confidence in that number is going down with the publication of multiple trials not showing superiority. Isolated TBI, nah. Crash 3 in the pre-hospital study said no superiority for the primary outcome. Postpartum hemorrhage, no, woman's trial did not show an all-cause mortality benefit. That's what we really care about, all-cause, not disease-specific mortality. For GI bleeds, no, the HALT-IT trial showed no difference in GI mortality at 5 days or all-cause mortality at 28 days. But there was that signal of increased harm that was statistically significant, a 0.4% increase in VTE. Intracranial hemorrhage, no. TITCH2 and ULTRA showed no superiority with good neuro or mortality. And then Epistaxis, I've got a question mark of unsure. There's a couple of smaller unblinded trials using 500 milligrams saying yes, and then we've got a larger blinded trial using 200 milligrams in different patients who had not responded to usual care saying no, and they had different primary outcomes. So I've got a question mark for that one. And then finally, Hemostasis, I'm unsure. Small study, reported superiority, so we need a replication study to know if TXA works in non-massive Hemostasis. Thank you.